The truth about back pain relief. 90% of videos get this wrong. If you've searched YouTube for back pain relief, you've probably watched videos telling you to fix your posture, strengthen your core, or get an MRI to see what's really wrong. Here is the problem. These ideas sound logical, but they contradict decades of clinical research. When researchers analyzed the 200 most popular YouTube back pain videos, they found that only 50% aligned with evidence-based guidelines. Today, we're cutting through the noise to reveal what actually works, backed by clinical science, not viral trends. The misinformation problem. Before we dive into solutions, let's understand why so much back pain content is misleading. YouTube is now a primary source for medical advice, but popularity doesn't equal accuracy. Research examining the most viewed back pain content discovered something alarming. Only 30% of videos provided diagnostic recommendations consistent with clinical guidelines. Another 80% of yoga for back pain videos promoted outdated biomechanical explanations that don't reflect current science. Why does this happen? The elements that make videos go viral, sensational claims, quick fixes, dramatic transformations, rarely align with what peer-reviewed research actually shows. When patients adopt unhelpful beliefs like pain always means tissue damage or I need an MRI to diagnose back pain, these false beliefs amplify disability and delay recovery. The good news? The evidence on what actually works is remarkably clear once you know where to look. What clinical guidelines actually say? The American College of Physicians, the World Health Organization, and the NIH-backed Back Pain Consortium have all synthesized decades of research into clear recommendations. Let me break down what they say. For acute pain, that is, less than 12 weeks duration, the guidelines recommend non-pharmacological treatment first. Superficial heat, massage, acupuncture, or spinal manipulation. Here is what's important. Most patients improve regardless of treatment. 70 to 95% of acute back pain resolves within 6 months naturally. For chronic back pain, the evidence supports exercise, multidisciplinary rehabilitation, acupuncture, mindfulness-based stress reduction, yoga, and cognitive behavioral therapy. The World Health Organization emphasizes a holistic, person-centered approach addressing physical, psychological, and social factors, not just structural mechanics. What the guidelines don't recommend: routine imaging, prolonged rest, expensive spinal fusion surgery, and long-term opioid medications for primary back pain without neurological compromise. This shift away from biomedical interventions towards self-management and psychological approaches represents the biggest change in pain science over the last 3 decades. The 5 myths. Let's systematically debunk the most damaging myths. Myth number 1. You need imaging to diagnose back pain. Many videos suggest getting an MRI or X-ray to see what's wrong with your spine. Here is what the evidence shows. 26% of medical images ordered are inappropriate. Why? Because scary-looking spinal degeneration appears on MRI in high percentages of pain-free people. Clinical guidelines strongly discourage routine imaging for low back pain because it produces false alarms, not useful information. The real harm comes next. Once you see a degenerative disc on an MRI, you carry that finding like a cognitive scar. Future pain episodes get attributed to the abnormal finding, regardless of whether it's actually causing the problem. This increases fear, reduces activity, and paradoxically worsens outcomes. Imaging is appropriate when you have red flags. Stay tuned till the end to find out what these red flags are. But for typical back pain, imaging is unnecessary and often harmful. Myth number 2. Bed rest is the best treatment. Wrong. Bed rest can cause more harm than good. It increases joint stiffness, muscle wasting, loss of bone density, and paradoxically makes pain worse long term. Studies comparing rest versus staying active show no differences or slight advantages for staying active. Modern guidelines consistently recommend staying as active as tolerated. Movement isn't something to fear, it's medicine. Myth number 3, core stability is the solution. This is perhaps the most pervasive myth, spawning a multi-billion-dollar industry. But the evidence? Weak to non-existent. A systematic review titled Core Stability and Low Back Pain, a Causal Fallacy, states bluntly, the claim that core stability exercise is one of the most effective options for low back pain is without merit. Here is why. There is no evidence that weak core muscles cause back pain in the first place. Yes, pain changes how your core muscles activate, but fixing the activation pattern doesn't fix the pain. Full body exercise works, but not because it targets mythical core dysfunction. The benefits likely come from improved fitness, reduced fear avoidance, and enhanced confidence. Myth number 4, perfect posture prevents pain. Multiple systematic reviews conclude that no evidence supports an ideal posture. Studies show people with severe postural abnormalities may have no pain, while those with perfect posture can be severely disabled. Here is the real problem. Maintaining rigid posture creates tension and restriction. Your body is designed for movement, not static alignment. Clinical guidelines now recommend varying sitting posture rather than holding any single position. The best posture? Your next posture. Move around. Myth number 5. Surgery cures chronic back pain. This one needs special attention because it's dangerous. Surgery is not recommended for primary back dominant pain without neurological deficits. Here is what the data shows. 8 to 40% of patients who undergo spinal fusion develop intractable pain afterward, called failed back surgery syndrome. Long-term complications include adjacent segment disease, that is, fusion causes accelerated degeneration at neighboring vertebrae, hardware problems, chronic pain persistence, and loss of spinal mobility. Surgery should be reserved for specific structural problems like cauda equina syndrome or progressive neurological deficit, not as a last resort for general chronic pain. Understanding the biopsychosocial model. Here is the conceptual shift that changes everything. Pain doesn't equal tissue damage, and structural findings don't predict symptoms. For centuries, we believed pain was a direct signal of tissue damage, but modern pain science reveals something different. Pain is processed through your brain, which integrates multiple inputs: actual tissue signals, past experiences, beliefs about threat, emotional state, social context, and attention. This isn't saying pain is all in your head. It's recognizing that tissue damage is only one factor among many. This explains why imaging findings don't correlate with symptoms. It explains why some people with severe disc degeneration have no pain, while others with minimal findings are severely disabled. Psychological factors powerfully predict outcomes. Pain catastrophizing, that is, the tendency to assume the worst, predicts poor surgical outcomes and higher disability better than any medical test. Fear avoidance beliefs and kinesiophobia, that is, fear of movement, drive disability more than actual tissue damage. The biopsychosocial model says chronic back pain involves biological, psychological, and social factors. Effective treatment must address all three. Now let's talk about what actually works. Now for some good news. Several interventions have strong evidence. 1. Pain neuroscience education. The most underrated intervention is education. teaching patients that pain doesn't provide an accurate measure of tissue state, that pain is modulated by many factors, and that chronic pain involves central nervous system changes. This alone improves outcomes. When you understand that your pain results from brain plasticity and central sensitization rather than a bad spine, you reduce fear and improve your ability to move. Studies show pain neuroscience education combined with exercise yields significant improvements in pain, disability, and physical performance. This is the purpose of this channel, to educate you about your pain. Subscribe to get notified about more educational content like this. 2. Exercise therapy. Exercise is one of the most consistently supported interventions across all guidelines. The type matters less than consistency and progression. Walking, yoga, tai chi, strength training, they all work because they build confidence, improve fitness, and challenge fear avoidance beliefs. But here is the key. Active interventions beat passive ones. Patients who received only passive treatments like massage or manipulation without exercise had higher rates of opioid use, injections, and specialty care escalation compared to those who engaged in active movement. 3. Manual therapy plus exercise. Manual therapy alone has limited evidence, but combined with specific exercise and education, it's beneficial, particularly in early stages. The mechanism isn't fixing joints. It's providing reassurance and enabling more active participation. 4. Multidisciplinary care. The strongest evidence supports combining multiple modalities: exercise, education, manual therapy, cognitive behavioral therapy, and self-management strategies. Patients receiving multimodal care showed better outcomes, reduced medication dependence, and improved quality of life compared to single modality approaches. 5. Self-management. The most important intervention, empowering patients to manage their own condition. This means learning problem-solving skills, setting value-based goals, understanding pain mechanisms, and building self-efficacy. Research shows shorter interventions, that is 6 to 8 weeks, are more effective than prolonged treatment because the goal is independence, not dependence on healthcare providers. The critical window. Here is something most content creators miss. The transition from acute to chronic pain is preventable. Most acute pain improves within 2 to 6 weeks, with further gains through 12 weeks. But pain persisting beyond 12 weeks becomes significantly harder to treat. This 6 to 12 week window is critical. Early appropriate intervention, particularly physical therapy with education and exercise, dramatically reduces the risk of chronicity. When intervention is delayed, imaging increases, opioid use increases, and costs skyrocket. The message: if your back pain isn't improving in 2 to 3 weeks, don't wait. Get evaluated and start active recovery strategies. Early intervention prevents the transition to chronic pain. Now, let's talk about the red flags. This is when to seek urgent care. While most back pain is benign and self-limiting, certain symptoms require immediate medical evaluation. 1. Cauda equina syndrome. This is a surgical emergency. Symptoms include sudden severe back pain with bilateral leg pain or progressive pain from one side to both, loss of bowel or bladder control, saddle anesthesia, that is numbness in the genital area, severe progressive weakness in the lower extremities. 2. Suspected infection. Symptoms include fever with back pain. 3. Severe unremitting pain, that is pain that is unabating or continuous. 4. A history of intravenous drug use or immunosuppression. 5. Suspected fracture. 6. Significant trauma or fall. 7. Age over 50 with new onset pain. 8. Use of corticosteroids. 9. Suspected cancer with a history of age 50 plus with new onset back pain. unexplained weight loss, night pain or pain at rest, a history of cancer. 10. No improvement after 4 to 6 weeks. 11. Progressive neurological deficits, that is, worsening weakness, foot drops, widespread neurological symptoms. If you have any of these, seek immediate medical attention. These conditions require urgent diagnosis and treatment. For everyone else, your back pain is probably benign and manageable with the strategies we've discussed. What you should actually do. Let me give you a practical roadmap. For acute pain, that is in the first 6 weeks, stay as active as tolerated. Use superficial heat for comfort. Take over-the-counter NSAIDs, that is medications like ibuprofen, if needed. Most importantly, don't catastrophize. 70 to 95% of acute pain resolves within 6 months. Don't seek imaging unless red flags are present. For subacute pain, that is 6 to 12 weeks duration. This is your critical window. Engage in structured exercise. Consider combining physical therapy with education about pain neuroscience. Address fear avoidance beliefs. Challenge the idea that certain movements are dangerous. Begin developing self-management strategies. These interventions prevent the transition to chronic pain. For chronic pain, that is pain that has gone beyond 12 weeks, adopt a comprehensive approach. Combine exercise, education, manual therapy, and cognitive behavioral therapy. Focus on valued activities rather than pain elimination. Build self-efficacy through successful experiences. Address sleep, stress, and lifestyle factors. If available, consider a multidisciplinary pain program. General principles. Embrace movement variability. No single correct way to move exists. Vary your positions throughout the day. Challenge fear avoidance beliefs. Your back is strong and resilient, not fragile. Pain doesn't always mean damage. And remember, pain flare-ups are normal and don't mean you've re-injured yourself. Conclusion. The evidence is crystal clear. 90% of back pain content gets it wrong by promoting myths while ignoring robust science. The gap between research and online content has real consequences. When patients adopt unhelpful beliefs, pursue inappropriate imaging, avoid beneficial activity, and escalate to unnecessary medications and surgeries, the cycle of disability perpetuates. But when patients are educated about pain mechanisms, empowered to move, taught self-management strategies, and supported by evidence-based multimodal care, outcomes transform dramatically. Here is what the evidence actually supports. Education first. Understanding pain reduces fear and improves outcomes. Movement is medicine. Exercise and activity are more powerful than passive interventions. Psychological factors matter. Addressing catastrophizing and fear avoidance is essential. Self-management is key. Building your own ability to manage pain prevents dependence. Multidisciplinary care works best. Addressing biological, psychological, and social factors yields the best results. Early intervention prevents chronicity. The 6 to 12 week window is critical. This isn't just theory. These principles come from clinical practice guidelines from the American College of Physicians, the World Health Organization, and leading research institutions. They represent the consensus of experts who've synthesized thousands of studies. The revolution in pain science over 3 decades has transformed back pain from a simplistic mechanical problem to a complex biopsychosocial condition requiring sophisticated individualized care. And that care looks very different from what 90% of YouTube videos promote. Your next steps. If you have back pain, check for red flags. Stay active. Educate yourself about pain neuroscience. Build your self-efficacy. Seek evidence-based care with a physical therapist. Be patient but proactive. The truth about back pain relief isn't found in quick fixes or magic exercises. It's found in understanding complexity, embracing movement despite discomfort, addressing unhelpful beliefs, and building the skills to manage what, for many, is a recurrent condition requiring long-term self-management. If this video helped you understand back pain differently, please share it with someone struggling. Subscribe to the DrYinka Pain Relief channel for more evidence-based content and comment below. Which myth surprised you the most? Let's build a community that values science over sensationalism. Remember, your back is strong, movement is medicine, and you have more control than you've been led to believe. The content of this video is not medical advice. It's educational only. See your doctor for medical advice. Thanks for listening.